All right, everyone. My name is Ashley. I'm the program director for IVUmed. We're very excited for this lecture with Dr. Amanda Saltzman. She is a pediatric urologist specializing in urologic oncology at University of Kentucky. And I will let her take over from here and correct me if I was wrong.
No, that's exactly right. Thank you, both Ashley and Dr. Kingongo for inviting me to do this. I'm really, really excited to talk to you guys, and hopefully we'll be able to cover everything that we want to in this hour. I don't have any disclosures, but the one thing that I'll say before I start is that I'm a surgeon, so I don't give chemotherapy or radiation. And so while we will talk about those things, there are definitely some nuances that I'm not going to get into just because it's outside of what I do. And as Ashley mentioned, I practice in the United States. So generally, my practice, we use COG protocols and guidelines. So there's going to be a little bit of a COG slant to this, but I've tried to incorporate the PSYOP protocols, as you guys generally seem to follow those, and highlight some differences in between, just so that you have awareness of those differences. So who am I? I've never met any of you guys before. I'm actually originally from Toronto, Canada, and I moved down to the United States to do medical school and residency in New Orleans. And I actually was an IVUmed scholar in October of 2014. I went to Lusaka, Zambia, to work with Dr. Fran Schneck and Dr. Heidi Stephanie as they came over. And it was just an absolutely fabulous experience that I hope to get involved with again in the future. I did my fellowship in Denver, Colorado, and they have a really unique program there. They have a lot of oncology that they do. And so that was why I decided to do my fellowship there and get that extra intense training. And then, as Ashley mentioned, I'm an associate professor of urology and pediatrics here at the University of Kentucky in Lexington. Now, Lexington, Kentucky is not a place that you guys probably know much about, but the University of Kentucky specifically is really known for its incredible basketball program. And actually in 2022, there were 27 players on the NBA, playing in the NBA that were from the University of Kentucky, and that's the most from any college in the United States. Lexington is very close to Louisville, which is where the Kentucky Derby happens, and there's a lot of horse racing in this general part of the country, and it is the birthplace of bourbon. So what we're going to go through today, we're going to do a quick introduction. We're going to talk about some basic PSYOP versus COG tenets in treating mainly kidney tumors. Our first case is going to be a unilateral renal mass, and then we'll be focusing on initial workup, the role of biopsy and operative plans. The second case is going to be a patient with bilateral renal masses. And then the third case is going to be a pelvic mass, to talk about some of the nuances in when we do surgery for those cases. So as I mentioned, this is going to kind of be a COG-centric talk, but I'm going to talk a lot about some of the differences that with those PSYOP protocols. In general, when we're talking about treating young kids with cancer, the overwhelming goal is always to minimize treatment-related morbidity and late effects. We have become really, really good at treating the cancers that now we're focusing on trying to make sure long-term that these patients do really well and don't suffer issues related to what we did to save their life and conquer their cancer. There are a lot of updates in management that are coming soon, at least from the COG side. And I'll mention a few of these. I am a little bit less familiar if PSYOP is having some new studies and protocols coming out soon, but I would anticipate that there probably will be some things coming soon. Caring for kids with cancer is really a team sport. It is so, I cannot overemphasize how important it is to make sure that you're discussing the patients and your plans with all of your friends. So with your oncologists, with your radiologists, with your surgery and urology colleagues, with pathology, with radiation oncology. We do so much better caring for patients when we work together and we don't make decisions in silos. And some of the things that I have learned in discussing patients with oncology and radiology and pathology have really opened my eyes and really, I think, made me a better surgeon because I'm thinking about things from different aspects. So into the nitty gritty, Wilms tumor. This is the second most common abdominal tumor in children after neuroblastoma. The vast majority of cases are unilateral, and they're typically found in patients between age 2 and 5. They're mostly sporadic. There is more likely to be some kind of predisposition if the patient has bilateral masses, and then bilateral masses are more likely to be anaplastic, which is associated with a much more aggressive disease. In general, renal mass pathology is not known preoperatively. So when you approach a renal mass, you're not approaching it, this is Wilms tumor, this is a rhabdoid tumor. You are generally managing things the same way and covering all your bases so that no matter what the pathology comes back as, you've done the right thing. Survival for Wilms tumor is generally excellent. But we do know, and very relevant to you in Uganda, that outcomes are worse in low-income settings. So compared to the 90% plus overall survival that we see in North America, so overall survival can be 10 to 50%. And this is a whole variety of factors. Patients often present with more advanced disease. There's malnutrition issues, limited facility, but the biggest reason that I was reading about is actually failure to complete treatment. And this is often related to the cost of treatment. SIOP has developed the PODC, or the Collaborative Wilms Tumor Africa project, to help improve outcomes. And I actually printed this document preparing for this lecture, and it has some really good, useful information, which I'm sure all of you know about, but I would encourage you to have handy when you see a patient with Wilms tumor or a renal mass. So let's talk about the alphabet soup with Wilms tumor. So COG stands for the Children's Oncology Group. And generally, the stance for COG is early upfront surgery. They want to get the unaltered pathology. They want to see what the pathology is, and they want to avoid chemotherapy and the risks associated with chemotherapy for those who wouldn't benefit. And then there is stage-specific adjuvant therapy. Whereas for SIOP, so this is Europe and generally the rest of the world other than North America, and what you guys follow in Uganda, SIOP says, well, it's almost always Wilms tumor. In these young patients with renal masses, it's Wilms tumor. So give chemotherapy, operate after. And while some patients may get chemotherapy that perhaps don't need it, or it's not the quote unquote right chemotherapy for their pathology, the vast majority of kids will be downstaged, which means that subsequent therapy like radiation and doxorubicin, they can use less of it. The other advantage of using neoadjuvant therapy is that there are some carve-outs in the SIOP protocols to use minimally invasive surgery, laparoscopy, and also to do nephron-sparing surgery for unilateral renal masses, which is generally not advocated by COG. The important thing to remember, though, is that the outcomes are the same. So while the details are important, I think it's important not to get too bogged down in them, because the outcomes are the same. You just need to make sure that you're following one specific protocol and not necessarily picking and choosing from each, because we don't know how those outcomes will result. One of the key management points in Wilms tumor is the distinction of stage 3 disease. And the reason this is so important is because this is where your treatment intensification happens, and this is where you can have significant late effects. So to review these stage 3 criteria, some of these are a little bit different in SIOP versus COG, but if you have a preoperative rupture or an intraoperative spill, if you have positive lymph nodes, if you have a tumor thrombus, positive margins, if you have peritoneal implants, if you do a biopsy, those are all stage 3 criteria. Chemotherapy before resection obviously is advocated for in SIOP, but for COG, if you do give chemotherapy before resection, you will upstage that patient to stage 3. Important to note here as well, for SIOP positive margins, they specifically note that it needs to be viable tumor, not necrotic tumor or anything like that. So let's talk about the first case, and all of these cases are cases that I have done in the last 4 years. And so I'll tell you a few things where I would have done some things differently as well. So this was a 3-year-old female who presented with a left upper quadrant mass, vomiting, decreased appetite, and she had some gross hematuria. All of these things had been present for about a week, but the mass, the grandmother noticed during a diaper change just the day that she presented. She does have some absence seizures, and her father has neurofibromatosis, but there are no other predisposition syndromes that we could identify. And she does live with her grandmother. So this is just a picture of her physical exam. And what you can note here, as we often see with kids that present with renal tumors, is there's just a very obvious mass. And certainly the masses can be much larger than this as well. The other thing that's really important to note on your physical exam, look for subtle signs of various syndromes. So look for hemihypertrophy, which can be very, 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 very subtle. Look at the extremities, see if one is slightly larger than the other. And it's really important to delve into a good family history to determine if there are any other syndromes that may be present. The initial laboratory workup, did basic labs with a blood count and a complete metabolic panel. Those were all normal. Urinalysis did show some blood, but was otherwise negative, and the coagulation parameters were normal. Very important, about 8% of patients with Wilms tumor can have an acquired von Willebrand's disease, and that's the type of thing that you obviously want to know before you get into the operating room, rather than run into bleeding issues in the operating room. The specific Wilms Tumor Africa project also calls for blood films to look for malaria, HIV testing, and stool and urine microscopy. So the next step in management is an ultrasound. And what we did, there was a right upper quadrant ultrasound that showed a heterogeneous mass, and it really couldn't identify the kidney. So this ultrasound is really important because, while it may not tell you exactly what this is or the organ of origin, it can give you some clues to tailor then your next imaging study. And we've done some studies that have shown that doing an ultrasound first will decrease the radiation exposure and make the imaging more efficient and more ideal if you begin with an ultrasound. Again, per the Wilms Tumor Africa project, the minimum that is needed is an ultrasound and a chest x-ray before treatment. And PSYOP generally prefers MRI next as cross-sectional imaging. COG says MRI or CT, except in the cases of bilateral masses where really MRI is preferred. So this was her CT scan. And I'm going to just start on the right. You can see she has metastatic disease, these lesions in the lungs, and they're not small. And then here we can see that she has a large tumor originating from her left kidney. So to summarize, she's a unilateral left renal mass with lung metastasis, but no obvious syndrome. So your differential diagnosis here is Wilms, clear cell sarcoma of the kidney, rhabdoid tumor, a renal cell carcinoma, but also don't forget neuroblastoma and Burkitt's lymphoma in endemic areas. So the next becomes the fork in the road. Do you go neoadjuvant chemotherapy or directly to the OR? And generally, this is going to be guided by the protocol that you choose to follow. So I'll tell you, here in North America, we would go directly to the operating room, but for PSYOP protocols, you would go directly to chemotherapy. So the chemotherapy that PSYOP recommends is vincristine and actinomycin for 4 weeks, and then you re-image. If there are a couple carve-outs, if there is metastatic disease, they recommend actually 6 weeks and also adding doxorubicin. And if it's bilateral, then you want to, you do your neoadjuvant chemotherapy, you re-image at 6 weeks, and then you can give more, but you shouldn't go really beyond 9 to 12 weeks. There are also some other modifications. If the patient is less than 6 months old or older than 16, you can go directly to surgery. If the patient is very young, the chance that this is a congenital mesoblastic nephroma is much higher. So, and that's typically a benign disease that won't respond to chemotherapy. So you can go directly to the operating room. And if they're older, it's much more likely to be renal cell carcinoma, which obviously won't respond to the typical Wilms tumor chemotherapies. You may need to dose reduce for patients who are very, very young or who are very malnourished. And if you need to shrink the tumor more because you cannot do the operation, which absolutely can be the case, you can either prolong the chemotherapy and give more cycles, or you can intensify it by adding doxorubicin. And then the other thing that, because PSYOP does the neoadjuvant chemotherapy, sometimes this allows the consideration of minimally invasive surgery or a partial nephrectomy for a unilateral mass, depending on the response to chemotherapy. And this is something that we generally don't do in North America because we do surgery up front. So let's talk about biopsy really quick, because we biopsy lots of different types of cancers. And so why wouldn't we do it for these kidney tumors? Generally, there's about a 7% non-diagnostic rate, and the concordance between the renal mass biopsy pathology and the final pathology is about 92%. This is very good, but it's avoided by COG and PSYOP, and for different reasons. For COG, they're concerned about spill and recurrence that can happen along the biopsy tract. Now, there are a lot of studies that show that the risk of tract recurrence along the biopsy tract is very low risk, only about 0.5%. So it's a very low risk, but it's also not no risk. And then for PSYOP, the big argument is that it doesn't change management. So in patients who were less than age 10, it changed management in less than 5% of cases. However, it did change management in older patients. So in the younger patients, there's really no point. It's not going to change what you do. Older patients, maybe there is a little bit of a role. As far as risks, pain, infection, bleeding, and those are quoted at about 17%. And so what you can compare, the risk of the biopsy complication is much larger than the chance that this is going to change management, certainly in your younger patients. And so it hasn't been effective in avoiding unnecessary chemotherapy. So biopsy has really been abandoned. So a unilateral renal mass, really, nephrectomy is the gold standard if it is feasible. Okay, so what does feasible mean? And this is where there's a lot of surgical judgment. Certainly, if the lung disease, the metastatic disease, is so severe that anesthesia is unsafe, you don't go to surgery right away. If this will require resection of adjacent organs, the pancreas, the colon, significant organs, not the adrenals necessarily, then, we want to avoid doing surgery up front. The other time would be if there is a tumor thrombus above the hepatics. And do note that if you can spare the adrenal if the upper pole is not involved, or if there's a nice clear plane between the tumor and the adrenal gland. As I mentioned before, partial nephrectomy can be considered in special circumstances for PSYOP, but it's not really recommended for unilateral, non-syndromic, or non-predisposed patients in North America for COG. So the operative plan, going back to my patient, we went to the operating room and we started with a cystoscopy and a retrograde pyelogram. And I think this is a really important thing to think about. The reason for the retrograde pyelogram was she had hematuria at presentation, and sometimes there can be a tumor thrombus that goes through the collecting system and down the ureter. And certainly you want to know if that is present before you ligate the ureter distally to make sure you get the entire tumor and you don't come across the tumor and create an intraoperative spill unintentionally. We then proceeded with an open left nephrectomy with lymph node sampling, which we'll get to in a second. And then we placed a line if the pathology was appropriate. There are some nuances here with COG, and this is an area that's going to be changing. They're really trying to avoid adjuvant therapy, identify patients who maybe we can not do adjuvant therapy on. And so they're expanding their criteria for the very low risk patients. So this is going to be something that will be exciting to see the results of in the future. So when you're doing your radical nephrectomy for a large renal mass, it's really important to make a very large transabdominal incision. This is not the time to struggle with exposure because you need good visualization. When you go in, it's important to look at the acidic fluid. If the fluid is bloody, that may be an indication for preoperative rupture that occurred. And then that is something very important to note in your operative report, because that is a stage 3 criteria that then will mandate treatment intensification postoperatively. It's important to palpate the peritoneum and liver. And if there's anything suspicious, excise that completely. You want to ligate the ureter as low as you can, and then use that to trace up to the hilum. Palpate the renal vein for a thrombus. Even if imaging is negative, that's the type of thing you want to know before you come across the renal vein. And routine exploration of the contralateral side is only necessary if your preoperative imaging is suboptimal. So as long as you are confident in your preoperative imaging that there's no tumor on the other side, you don't need to routinely explore. So a quick word on lymph node sampling. I've done some work in this area, and this is a really, really important part of taking care of all patients with renal masses, but certainly in Wilms tumor. And this is mandated by all protocols for all patients. But I will be the first to admit that the guidance is very vague. It doesn't exactly say where to sample from, how many, or anything like that. And the lack of lymph node sampling is the most common surgical protocol violation. So this is something very easy we can do to improve the care for these patients. So why is this so important? Well, we know that positive lymph nodes is the most common reason that patients are designated stage 3. And we also know that accurate staging dictates treatment. So if we don't sample lymph nodes and we don't know that lymph nodes are involved, then the patient may be understaged and then subsequently undertreated, which we want to avoid. Lymph node involvement is predictive of relapse, but not overall survival in both COG and PSYOP studies. And we know that our pre-op on imaging and our intra-op just with our eyes by the surgeon, our assessment is very unreliable. So we can't say lymph nodes are involved or not based on imaging or our eyeball test alone. Where should we do this? There was an excellent study that came out of India in the last few years that looked at where tumors generally tend to go. And it's pretty clear that on the right, you're doing your paracables as well as your interaortal cable nodes. And on the left, you're doing the para-aortic and the interaortic cables. So the interaortal cable nodes need to be sampled whether you have a left or right tumor. Very, very important. How many? There's still a lot of debate on this, but generally the thought is about 6 to 10. And we know from some work that actually I published just in my first year as I was finishing fellowship in my first year as an attending here, that we can reduce the chance of missing occult metastatic disease to less than 10% if we sample about 6 to 10 lymph nodes. Lymph node sampling is something that is going to be studied by COG in upcoming studies, and they're actually going to be excluding patients from study if lymph nodes aren't sampled. So this is something that's really, really, really important. And as surgeons, this is a great way we can be involved and make sure we're doing the right thing for our patients. So we have some carve outs for minimally invasive surgery and nephron sparing surgery. I don't want to spend a ton of time on this because I think that these circumstances are pretty rare, but essentially, if you're going to do a laparoscopic nephrectomy for these patients, it's important that you still adhere to all the oncologic principles and do lymph node sampling. Generally, these tumors, they need to be small central tumors with a rim of healthy tissue. You need to extract them in a bag without rupture. So that's the same as you would do if it was open. If you have the ideal patient where you could do a laparoscopic nephrectomy or an open partial, you always want to try to save nephrons. So you would prioritize the nephron sparing surgery over laparoscopy. The tumor cannot cross the ipsilateral border of the spine, and you want to avoid it in cases where there's a thrombus, a peripheral location, or a tumor that hasn't responded well to chemotherapy because of the risk of spill. You also want to make sure you have an experienced surgeon, and it's good to get a reference opinion. Contact someone on the PSYOP renal tumor surgery committee or group, excuse me, to make sure that they agree that this is a case that is reasonable to be considered for laparoscopy. Nephron-sparing surgery is similar. This needs to be a single tumor, and it should be polar or peripheral in location, and the volume has to be small at diagnosis. Obviously, it has to be confined. You need to be able to do the partial nephrectomy safely with a negative margin, and you need to spare at least 2/3 of the kidney. And here it's okay to consider doing functional studies of the kidney before and after surgery and doing early ultrasounds to make sure that that the kidney that remains is okay. The other thing with this is if there are other issues or other criteria that make the patient stage 3, you do not need to go back and do a completion nephrectomy. Okay, so going back to my patient, we're almost done with her. Final pathology was favorable histology Wilms, negative margins. She had 15 lymph nodes that were negative. She was a local stage 2, but an overall stage 4. And unfortunately, with some of the more advanced genetic and molecular testing that we do after surgery, she had loss of heterozygosity at 1P and 16Q, and she had gain at 1Q. So this is where, as a surgeon, my brain starts to get a little bit overwhelmed with all of these acronyms, but all of these are molecular testing that they do on the pathologic specimen, and all of them are poor prognostic factors. So event-free survival, if you have these, is 65 to 75% compared to 85 to 90% if you do not. So these are bad actors, and these identify patients who may have a worse outcome. So she initially received DD4A, so that was vincristine, actinomycin, doxorubicin, but was changed to regimen M. So her chemotherapy was intensified after we got that genetic information back. And then she had abdomen and whole lung radiation, followed by multiple wedge resections of her lung. And unfortunately, actually just a few months ago, she recurred in her lungs and died of her disease at age 7. So she was about 4 years after she presented. Again, another difference with PSYOP that we have is PSYOP uses their histologic risk groups to guide their adjuvant therapy in addition to stage. And this is based on chemotherapy-induced changes in tumors, something that we can't do with COG because we operate right away. So your low-risk patients are patients who have completely necrotic tumors. Intermediate is the vast majority. These are your favorable histology tumors or those with just focal anaplasia. And then your high-risk patients are your diffuse anaplasia patients and blastemal predominant Wilms. And then their general treatment is as seen below. You're intensifying chemotherapy and adding radiation as the stage goes up and as their histologic group goes up. Okay, moving on to our bilateral renal mass patient. So this was a 12-month-old male who came in with just a left abdominal mass and otherwise had no symptoms, no family history of malignancies, nothing that would make you suspicious of a predisposition or a hereditary syndrome. Initial laboratory workup that we did, the same thing with the unilateral Wilms patient, was normal. And on imaging, we began with an ultrasound and then moved to a CT scan. And his chest was clear. The ultrasound just showed a left renal mass. And we reviewed this at tumor board literally the day before this patient was supposed to undergo an open left nephrectomy. And I think this is a really good example of making sure that you are communicating with lots of specialists, because at tumor board, this contralateral, this right-sided renal lesion was noted, and we were able to say, okay, this patient doesn't need a nephrectomy. They actually need to go on to neoadjuvant chemotherapy first. So this is most likely to be Wilms tumor. There's a very, very small handful of bilateral renal tumors where one was not Wilms tumor. Nothing from Europe, nothing from PSYOP. There are a few cases from Nitwitz, which was the it's essentially COG, North America, where they've had bilateral rhabdoid tumors, bilateral clear cell sarcomas, and bilateral renal cell carcinomas. But the vast majority are going to be Wilms tumors. And in these patients, we know that their disease can be more aggressive and that they're more likely to recur. So the goal is to save as many nephrons as we possibly can. Future renal failure that these patients experience, it's about 10%, and it's typically due to surgery. It's because we are taking out all of their kidney tissue. So it's really, really important to save as many nephrons as we possibly can. So we proceeded with chemotherapy without biopsy. He got vincristine, actinomycin, and doxorubicin for 6 weeks, and then we re-imaged. Important here without the biopsy comment. Biopsy will make patients per COG a local stage 3. And it does mandate adding doxorubicin, not radiation. But the point here is mainly that the vast majority of these are going to be Wilms tumor. So the biopsy doesn't necessarily help you. You don't necessarily gain information. But if you upstage the patient, now you've intensified them, which is something, and exposed them to more toxic therapies and potentially worse outcomes and worse morbidity later in life. So this is an MRI that was done after his first 6 weeks of chemotherapy. The 2 images on the left, you can see 2 small lesions in the lower pole of the kidney. And then on the, patient's right-sided kidney, but it's the pictures that are on the left. And the right-sided pictures, which is on the patient's left kidney, we can see obviously the large renal mass here, but you can see 2 other small peripheral lesions. So we looked at this in tumor board, and the patient had an appropriate response to chemotherapy. So they had an appropriate reduction in tumor volume. Important here, if the patient is not responding, you need to be very suspicious that this may not be Wilms tumor, and a biopsy is recommended. Generally, open biopsy is preferred over a percutaneous or radiology guided biopsy, generally because the identification of anaplasia has been shown to be better with an open biopsy, but I think you need to get some kind of tissue. We felt, looking at this, that a partial nephrectomy would be very difficult, if possible at all, on the left. So we elected to give another 6 weeks of chemotherapy, the same chemotherapy, and then we re-imaged. And these are the now 12 weeks of neoadjuvant chemotherapy images, and you can see that everything has shrunk. So now we felt that the left was amenable to a partial nephrectomy. So we went to the operating room for bilateral partial nephrectomies. So with PSYOP, they talk about 2 different types of nephron sparing surgery. They have NSSA, which is the true partial nephrectomy, where you have a rim of healthy tissue around the tumor. And then they have NSSB, which is enucleation. Both of these are acceptable. The key is that you need to have at least a 1 millimeter negative margin. So these are some pictures, intraoperative photos after the partial nephrectomy. And you can see here we used bolsters, cut out the tumor, used intraoperative ultrasound. I cannot overemphasize how useful that is to demarcate your margins of the tumor, to know exactly where to cut. And then you can see here we did our lymph node dissection, our paracables, and then we're going to get to the inner aortic cables on the other side. So here are, this is the patient's left-sided tumor. You can see this was the large tumor we took off, and then there's one in the back up here that you can see as well. And then this is after our node dissection, clearing the inner aortic cables and the para-aortic spaces. So this patient, the left lower pole was a favorable histology Wilms tumor, stage 2, but very interestingly, the lesion in the left upper pole and the tumors on his right were all cystic dysplasia. There was no tumor, which is really good news for this patient. And he had 8 negative lymph nodes. So he was a local and overall stage 2. So he got vincristine, actinomycin, and doxorubicin neoadjuvantly. But because he actually only ended up having a unilateral Wilms tumor, we were able to take off the doxorubicin and give him just 3 cycles of vincristine and actinomycin postoperatively. He's undergone serial imaging, and he's now without recurrence for 2 years. So that's a great story for that patient. All right. I'm going to switch gears and kind of go to rhabdomyosarcoma and the bladder part of this talk. Again, some more alphabet soup. The IRSG has essentially now molded into COG. So when you are looking at the literature and you see the IRSG, the different studies, you can think about that being very similar to COG. And then, we have PSYOP that has their protocols. Historically, rhabdomyosarcoma we treated with very radical surgical excision. And while the details vary on the treatment, whether you follow COG or PSYOP protocols, survival is about the same, just like in Wilms tumor. So when I first was learning about this and preparing various rhabdomyosarcoma talks that I've given, I found it very difficult to understand the differences between COG and PSYOP and how to understand why they're different. But essentially, if you look at the study goals, COG tries to minimize surgical morbidity and disfigurement, and they really try to preserve organs. Really relevant when you're talking about bladders, prostates, female reproductive organs. Whereas PSYOP, they try to minimize the use of local control by giving all the patients really intense chemotherapy up front. When we talk about local control, COG prefers radiation, whereas PSYOP generally prefers PSYOP prefers surgery with radiation only in select cases. The endpoint that the groups care about the most, COG cares about event-free survival, so recurrences, whereas PSYOP really cares about overall survival. And when it comes to salvage, COG really wants to avoid salvage therapy, so they'll accept some more toxic initial treatments, whereas PSYOP will accept a slightly lower event-free survival, and so some more recurrences, and have some higher salvage rates because they really care about the overall survival. So what are the outcomes? Again, just like Wilms tumor, there's no statistical difference based on your protocol. But if we look at all rhabdomyosarcoma, maybe you could say the event-free and overall survival is a little bit better for COG versus PSYOP. When we look at bladder prostate, very similar. And when we look at non-bladder prostate, also very similar. There are no statistical differences, so no one can say that one is better than the other. They're just different. All right. So this is a 4-month-old boy who presented with low oral intake and decreased urine and stool output for several days. He was born at term, no issues with pregnancy, no family history of malignancies, nothing suspicious in his history whatsoever. On exam, he was very fussy, very uncomfortable. His bladder was distended, we could feel it, and we could feel a very firm mass that was palpable in the pelvis, and on rectal exam, this was anterior to the rectum. When we put the Foley in, he had lots of urine that came out, and he was immediately much improved. Laboratory workup, so blood counts and blood chemistries were normal, urinalysis with a little bit of blood. We got alpha fetoprotein and HCG tumor markers, and those were normal. So his imaging, this is his ultrasound on the left-hand side of the screen. Bladder, you can see here, and you can see a large heterogeneous mass. This did have Doppler flow that is compressing the bladder. And then we subsequently got an MRI with the catheter in place. And what you can see here is this this tumor that's really pushing on the bladder. And it was really hard to determine where this tumor was coming from. And I think this is a really good example. I didn't have a really explicit conversation with the radiologist before ordering this MRI that I needed some really good sagittal cuts to look at if this was originating in the prostate, because that was my suspicion. And so I didn't get really good sagittal cuts. And so some better communication between me and the radiologist may have helped that and may have helped guide what we did next in the operating room. So your differential for a large pelvic mass like this is teratoma, rhabdomyosarcoma, neuroblastoma, and a GI duplication cyst. So I think and I don't know how many of you are pediatric surgeons versus pediatric urologists or, on the Zoom, but certainly when you approach a pelvic mass as a urologist, you are thinking prostate, you're thinking about all your GU organs, and it's really important to make sure you have a wide differential so that you aren't having tunnel vision. We had a multidisciplinary discussion between myself, the pediatric surgeons, and the pediatric oncologist, and we knew we needed tissue, so we needed to go to the OR. The question was, how are we going to get this? And so the thought was that this probably was a prostatic rhabdo. And so we started and attempted a cystoscopic biopsy, but I couldn't do this because there was no tumor present. It was just a super distorted urethra and a really high bladder neck. There was nothing for me to necessarily biopsy. So then we proceeded with a laparoscopic biopsy. And on laparoscopy, this mass appeared to be originating from the prostate. So we took a big biopsy. One of the things I would have also done differently here is I probably would have sampled some lymph nodes when we were in there, if I had to do it all over again, because that would have potentially given us some staging information. It ended up not really mattering for this patient, but if I were to do it over again, this would be something I would do differently. So let's talk about surgery in rhabdomyosarcoma and the potential timing of surgery, because this is where I think we can play a central role. So there's at diagnosis, after biopsy, but before chemotherapy, and this is called the pre-treatment re-excision. After chemotherapy, so this is either a DPE or a slow, delayed primary excision or a second look operation. And then after chemotherapy and radiation for salvage. So surgical crossroad number one is, how do I get tissue? And generally, the general tenet that should guide you is, if the mass can be completely resected without affecting that organ or bodily function or causing too much disfigurement, this is acceptable. And a great example is a paratesticular mass. We do a radical orchiectomy. We take out that whole testicle, and you don't do a biopsy or anything like that. But in most places, this isn't possible. So generally, you're doing a biopsy. And so your decision here about biopsy or a resection, it really affects the group assignment. So, we've got our sites, favorable versus unfavorable, and our stage, which incorporates the site as well as the TNM system. But then we have group, and this is really based on the completeness of your resection and your lymph node status, very importantly, before chemotherapy is given. And this is assigned by the surgeon. All right, so this is a key role that we have to play in the treatment of these patients. So this is more for reference. I'm not going to go through all of these details, but essentially you've got localized disease in your group ones. Your group twos, you have a total gross resection, but you may have some lymph nodes involved. And in group threes, you have an incomplete resection. After biopsy only, that's your 3As. And the vast majority of the non-paratestis rhabdomyosarcomas that we would take care of as a urologist probably are going to fall into that category. So, for example, let's say we have a 3-year-old boy with a bladder prostate rhabdo. Well, we know he can't be stage 1 because it's an unfavorable site, and we know he's going to require chemotherapy after his tissue diagnosis. So we have two options. If we do the biopsy only, we put him in group 3A. He's going to get his chemotherapy, and we know he's going to need local control after. The local control is either going to be radiation, which we know is associated with radiation cystitis, a risk of secondary malignancies, bowel issues, a whole host of other issues, or it's going to be a radical cystoprostatectomy, which comes with erectile dysfunction, incontinence, issues with diversions and whatnot. So neither of those really sound like great options. So it may be tempting to say, well, what if I just do a radical cystoprostatectomy up front with negative margins? He can be group 2, and so, we can reduce some of the therapy that he needs. And yeah, he'll have to deal with the urinary diversion, infertility, and ED, but we can down group him, and that would be great for the patient. So I'm going to jump to the pre-treatment re-excision real quick to explain why in bladder prostate rhabdo, it's very tempting to do that, but it should generally be avoided. So if after a biopsy and diagnosis, so you have your pathology, it's a rhabdomyosarcoma, if you can completely resect the lesion with minimal morbidity, you should do this before chemotherapy begins because you can group reduce them. And this is really commonly applied to non-bladder prostate rhabdomyosarcomas. A great example is a small bladder dome lesion that you can do a partial cystectomy on and do lymph node sampling. That's a perfect candidate for this concept of the pre. Unfortunately, with bladder prostate rhabdo, less than half of cases can achieve this negative margin with upfront surgery. So you do this big surgery, you end up with a positive margin, and then they're going to need radiation anyways. So now the patient has gotten the worst of both worlds. And so really, most experts in the field of rhabdomyosarcoma would tell you to resist the temptation to offer early extirpation. There are some cases where it's reasonable and it can be considered, but in general, really try to resist that temptation and definitely bounce that idea off of someone before you go down that road. So going back to our patient that we did the biopsy on. So this was an embryonal rhabdomyosarcoma, and this was the PAX-FOX01 fusion negative type. So there is a movement away from calling things embryonal versus alveolar because we've identified this fusion status, which generally is positive with the alveolars and negative with the embryonals. And that is really a risk factor to poor outcomes. If that fusion status is present, then that is much higher risk. This patient received, after his biopsy, 12 weeks of vincristine, actinomycin, and cyclophosphamide. PSYOP does slightly different medications, and they may or may not use an anthracycline, and then they used maintenance temsirolimus. And actually, the outcomes have been excellent with that is now one of the study arms on the COG studies. So let's talk about local control. So as I mentioned, PSYOP generally prefers surgery early. So excise the tumor up front when you can. And the reason why is if you can get them to be a group 1, then they don't need radiation, which is great for the patient. And then, as I mentioned, you can consider re-excision after you start therapy. Radiation is preferred by COG, and this begins somewhere, in the 3 to 15 week range. The doses are not insignificant, they are high. And frequently there is a residual mass after radiation, about 20%, 1 in 5 patients. There is no change or there's no effect of this on recurrence. So whether you have a mass or don't have a mass, you're not more or less likely to recur, which is important to know. So now let's talk about the DPE, or the delayed primary excision. So we know that in all the protocols, if you have a positive margin, the patient needs to have radiation in some form, okay? So the delayed primary excision allows for surgical excision with a negative margin after chemotherapy to reduce the dose of radiation given in COG protocols. I'll be the first to admit, in PSYOP, I'm not sure if it dose reduces it or if it allows complete omission of radiation. I believe it's complete omission, but I'm not as familiar with that detail of the protocol. So if that is incorrect, I apologize. So the idea is, if you can do a radical surgery, achieve a negative margin, then the patient will receive much less radiation. So 50 gray if there is gross disease versus just 36 gray. And in patients that are babies, this is really the time that this should be considered. So lots of people don't like to do radiation to the bladder because it damages the bladder. And studies have shown that about 40%, so not even half, of bladder prostate rhabdo patients will survive event-free, so just from their disease, with normally functioning bladders. Okay, we know that the radiation dose affects bladder outcomes, and the outcomes deteriorate over time. So this 40% that I quoted you probably is even less if we followed the patients longer. And in a historical study, the only patients with bladder prostate rhabdo who had normal bladder function on urodynamic studies were those who did not receive pelvic radiation. So pelvic radiation is no joke. It absolutely can damage bladders and cause issues in the future for these patients. And so this has led to the investigation of proton beam therapy and brachytherapy for patients with pelvic rhabdomyosarcoma. This is still off protocol, but this is probably going to be the way of the future, and I'm excited to see what will happen in that area. So these are my personal thoughts. These are not mandated by any protocol. COG and PSYOP, they have the same outcomes. I do prefer radiation for local control unless the patient is very, very young. And my reasoning for this is, even if the bladder function deteriorates and the bladder is awful and you have to do reconstruction, at least you've given them the chance that there is no further surgery that may be necessary. And having that bladder, whether it's defunctionalized or not, you preserve the ureterovesical junction, and you've got a plate for an augment and a Mitrofanop over a complete neobladder reconstruction. So again, that's thinking a few steps ahead for these patients longer term. But my general thought, and it also helps that I practice in North America where we use COG protocols, is that radiation is the way to go for these patients. A very, very quick word on residual masses after chemotherapy and radiation. As I mentioned, 1 in 5 cases will have this. It may require a second look operation to assess the response and potentially allow surgical control. But it's very important that, particularly on frozen section, you may get mature rhabdomyoblasts, and this can be really easily confused with active disease. So they may call active disease, but it's just mature rhabdomyoblasts, or vice versa. And if you have mature rhabdomyoblasts only, recurrence is very, very low. There have been some deaths, but generally you don't treat them. And you certainly wouldn't want to, if they confuse mature rhabdomyoblasts with active disease and then you do a large surgery and the final comes back as mature rhabdomyoblasts, you probably, you potentially harmed the patient doing a surgery that they wouldn't need. So my last slide, in conclusion, remember that the goal for taking care of these patients is to increase survival, but also while decreasing harmful exposures. Think about radiation from imaging. Think about radiation and chemotherapy that can result from our intraoperative decisions and margin status. And this is something really important to think about as the surgeon. I cannot overemphasize, talk to your oncologist, your radiation oncologist, your pathologist, everyone that's involved in taking care of this patient. Try to avoid making any decisions that may be detrimental for the patient, that's obvious, but also try to avoid making decisions that can make other people be placed in a difficult spot. Avoid being stranded on an island alone where you were the only one that made that decision, and try to think a few steps ahead to anticipate how your decisions may impact the future care of the patient. Because as surgeons, it's doing the surgery is the easy part. It's making the decision and making the right decision at the right time for the patient, and anticipating how that may affect the future of the patient. That is the really, really important step. A very quick shout out to all of you in Uganda. We are now we have a pediatric adolescent young adult urologic oncology course that we are running. This will be the 2nd year that we're running it. And we do have a virtual option. As I imagine, traveling to Denver, Colorado, although it's a beautiful place at that time of year, maybe a little bit prohibitive. So please, you can reach out to me if you have any questions. We would love to have you online, virtually, or in person if you can make it. And you are more than welcome to contact me anytime, phone, email, Twitter. I'm more than happy to talk about cases or offer any help, support that I can. And thank you guys so much again for having me today.
Thank you so much, Dr. Saltzman. That was a wonderful lecture. And we'll open it up to questions. Dr. Kigongo, any questions on your end?
I am monitoring the chat, see, so far none. But personally, from what I've noted as the presentation goes on, I would love to know how fertility concerns for these children as they receive cancer care. What's the long-term outcome? How do you try to preserve fertility?
Sorry, you cut out at the beginning for the Wilms patients or for the rhabdomyosarcoma patients?
For both, but mostly the rhabdo. I see. I think for the rhabdo, if you're going to do surgery, then I don't know, they will have to use assisted reproduction, isn't it?
Yeah, so, rhabdo, even without the surgery, because they're getting very high doses of cyclophosphamide, their fertility is going to be affected. And we don't have any way, we haven't successfully been able to have bank any sperm from prepubertal patients that then have resulted in pregnancy. It's coming for sure, but we haven't successfully done that yet. And then certainly once you talk about doing surgery, a radical cystoprostatectomy, not only do you have you've got issues with sperm production, you have issues with ejaculation, erection. Yeah, you're going to need to use kind of all the tricks that we have to achieve pregnancy and assisted reproduction. It's really not a great option. These patients, I have several patients that are teenagers and actually young adults that I didn't see personally when they were young, but that I have seen in follow-up. And, there are patients who do really well. What has been striking to me is that the patients that I've seen that have received pelvic radiation, their pelvises are frozen and very, very small. And the orthopedic issues that can result from that are significant. And that's something that I didn't appreciate until I had seen some of these older patients and the survivors. There are lots of patients also that I've seen that have an ileal conduit after having their rhabdomyosarcoma resected, and they're perfectly happy with their conduit. I think a lot of us doing surgery, a lot of it is managing expectations and being really honest up front about what the future holds, and not painting a dim picture, but being honest and also not painting a picture of rainbows and butterflies, because the morbidity of surgery is not insignificant in these patients.
Right. One more question about, you talked about the re-excision of the rhabdo before chemotherapy. Typically, what's your timeline from biopsy? You get results, you discuss results, then decide to do a re-excision. How much time would it take?
I would usually want to do it kind of as soon as possible. So here in the United States, if I do a biopsy, I usually will have results in 5 or so days. And then I would review everything with my oncologist and to make sure everyone was on the same page, and then look to go to the operating room, ideally within 2 weeks.
Oh, okay.
But I will say that's personal preference. I don't believe there is a specific timeline. The key is to do it before the chemotherapy is given.
Okay, I get it now. Those are my questions. I don't know whether other people have. Oh, there's a question from my teacher, Professor Kyria and Professor Wata.
Yeah, thank you very much. I'm in a company of another resident here. We are using the same gadget, so he's going to ask the question. Otherwise, thank you very much, Dr. Amanda, for the insightful lecture you've given us.
Oh, thank you guys very much.
Yeah.
Okay, thank you so much, Dr. Amanda, for the wonderful presentation. Personally, I have special interest in Wilms tumor, and I've been doing a lot of them with my bosses. Personally, in our setting, the main problem we have with these children is delay in timely surgery because of logistics, like they don't usually have money maybe to do investigation, pre-op investigations, but then also loss to follow up is also a very big problem. My concern is about the first case that you presented, because it seems he had pulmonary metastasis that puts the child on stage 4. But then the team adapted COG versus PSYOP. So I wanted you to comment on, when do you consider PSYOP in your setting? Yes, I wanted you to throw more light on that, because in our setting, grade 3 and grade 4, stage 4, that is automatically a PSYOP. Then also I wanted you to comment on the indications of nephron sparing surgery in a unilateral Wilms tumor, because I know one of the indications is if that patient have predisposition syndrome like Dennis-Drush and Beckwith-Wiedemann syndrome, because you know that the risk of getting Wilms tumor in the contralateral side is there. I'm not so sure about the percentage or the values. Thank you for that.
Yeah, so great questions. So COG versus PSYOP, when you have a patient with obvious stage 4 disease for Wilms, that's essentially the first question. So just because they have, you know, when you stage Wilms tumor, you have a local stage and you have an overall stage, okay? And the local stage will determine if they need radiation. Okay, so the thought process is, okay, it's metastasized. They're going to need some doxorubicin, but we don't know about we don't know the local stage yet. So when we take out the tumor, and if she hadn't ruptured, she would have been actually a local stage 2 and may not have needed radiation to her abdomen. Okay, so the idea behind going to surgery first is to try to do everything you can to avoid radiation to the abdomen, and in the absence of mets, potentially doxorubicin. The other caveat is, in North America, and I think it's the vast majority of at least institutions in the United States, everyone that I've trained in or been at as an attending, COG really guides the way. And, you know, I would not want to make a decision to say, oh, we're going to do PSYOP for this patient, because I need my oncologist to be on board. And that's, again, why I think it's really, really, really important. Talk to your oncologist and make sure that they agree. A really good example of this is I had a 5-year-old girl, so within the age for Wilms tumor, who had a history of neuroblastoma as a kid. As I think she was about 1, and she came with a unilateral upper pole renal mass. And so per COG protocols, you would do a radical nephrectomy. But given her history, I was very high, and the mass being small, upper pole, amenable to a partial, I knew it was very likely to be a translocation cell, renal cell carcinoma. So I talked to the oncologist, and we had a conversation about that. We both did our background research. We talked, and they agreed, okay, let's do a partial. And then the next part of that conversation was, okay, if we do a partial, and I'm going to send it for a frozen, if it comes back Wilms tumor, will you be okay with me just doing a partial, or do you want me to do a completion nephrectomy? So we anticipated what would happen next. So it's okay to go off protocol, but I think the key point is you want to make sure you're not doing it alone. And you want to make sure that if you say, okay, I'm going to follow COG, I'm going to do an upfront nephrectomy, if your oncologist then gets that and says, well, that's not what I would have done, and now I don't know, like, how do I quote outcomes to the family? How do I talk about that? You know, it kind of puts them in an awkward situation. And not that you've done anything wrong, you haven't, but it's easier to have that conversation up front. But in general, in wherever I have been, COG is kind of the default. And to go off of that, you need to have a multidisciplinary discussion. Second question was nephron sparing surgery in the unilateral patient. So anyone with a solitary kidney, any of the known predisposition syndromes, so Beckwith-Wiedemann, Denny's-Drash, things that Wagger, things you mentioned, certainly those are patients that you want to be doing partial nephrectomies for, anyone with a bilateral tumor. Again, per COG, outside of those, partial nephrectomy, they don't recommend partial nephrectomy. So again, that example I gave you of the patient that we were highly suspicious of a translocation cell renal cell carcinoma, you can go off protocol, but you just have to have that discussion, and you have to kind of prospectively think, what if I'm wrong? And you don't want to make that decision alone. You want to make sure that, okay, if I'm wrong, you have a game plan, and you have other people with you who are in agreement with your plan. I think as far as unilateral Wilms in North America, most people are not doing it, except for very select circumstances. The other thing I would say is, I don't know how it is where you guys are. The vast majority of unilateral Wilms that I've seen are these huge, gigantic masses that you can't usually do a partial on anyways. So that discussion, I think, is much more relevant for the post-chemotherapy, the neoadjuvant chemotherapy space, as SIOP has demonstrated, where you can shrink the tumor down, which is awesome, and then you can do the partial nephrectomy. But I think if you're going to do surgery up front, there just aren't a lot of patients that are amenable to a partial. Hopefully that answered your question.
Yes, thank you so much for your submission.
And then it looks like Stephen, you have your hand up.
Thank you, Dr. Amanda, for your nice presentation. We have understood a lot. I just want to understand how your system functions. You are the primary contact with the patients. How do you interact with the oncologists and the radiotherapists? Do you take the decisions primarily in the beginning, then you send the patient to the oncologist? Do you function every case that you have to sit down together as a whole group before decision making? I just want to have an idea how this functions.
So it really depends on how the patient presents and where the patient presents. A lot of these patients present to the emergency room, either with hematuria or big mass. And generally, the emergency room will call the pediatric oncologist, and they will start seeing them, order the initial ultrasound and the labs, and then they call the, me or one of the pediatric surgeons, they call the surgical person. And then, we talk together about kind of what we see, make sure we have all our imaging studies that we want ordered. If there are, we work really closely that if there's sometimes, they'll want an MRI, but I'll want a CT for, as long, and we'll just discuss it. Sometimes they want an MRI to avoid the radiation, which is totally great. But for me, I get a lot more information surgically for my surgical planning from a CT scan. So there are times where I'll push a little bit more for I really need a CT scan. I need to see a little bit more information for me for surgical planning. And then we meet weekly with a multidisciplinary tumor board. So we have a pathologist, me, the urologist, we have our oncologists come, radiologists, and we have all of our nursing support as well. And we meet and we talk about the cases, and we, get expertise from everyone, whether they've seen the patient or not. But typically, you know, oncology and urology, we work together, we come up with a plan. I make it a point to email my pathologist when I'm going to do the nephrectomy to tell them a little bit about the patient, because they don't always know what I'm looking for, and any other specific details if I really need to know margin status or something like that. And they've been incredibly receptive and really happy, and it helps them do their job really, really, really well, to have that communication. And then after surgery, you know, the patient gets admitted to me, we do the post-op care, and then again, we meet with tumor board. If we haven't met about the patient already, we come up with the plan, and then, you know, radiation starts and the chemotherapy starts thereafter. And generally then oncology kind of takes over and they're driving the boat. But I make it a point to try to come up and visit with the families at all of their visits to at least say hello, make sure their incisions are okay. But it's a lot of back and forth, and that relationship between your oncologist and you is incredibly, incredibly, incredibly important. As far as the, you know, the getting patients in and communication, that's a challenge even here. There are lots of patients that I do operations on, not even necessarily with tumors, that you do an operation and they disappear and you can't get them back. And it's generally a big problem. I know that at least reading through the Wilms Tumor Africa project, there was a lot of talk about providing people with cell phones, with transportation, with lodging. Realistically, you know, I don't know how much that is a feasible thing and how possible that is. Even here in the United States, I mean, we can't always put people up and all of those types of things. So it's a challenge. I know my nurses are really good about phone calls, emails, text messages, you know, making sure you're using as many communication modes as you possibly can is really helpful. Sometimes I give, actually all my oncology patients, I give them my personal cell phone so that if they have a problem, they can reach out to me. Very few ever do, but it makes them feel comfortable that they have it. But I certainly wouldn't tell anyone that you have to do that for your patients, because we have to draw a line in the sand somewhere. So hopefully that helped answer your question. I don't know if I had any really good answers, but that's what we do here.
Thank you very much.
I see two hands. I don't know who wants to go first.
I can go first. Thank you, Dr. Amanda, for the presentation. My question, I'm seeking some advice on the pelvic tumors, especially where you're suspecting rhabdomyosarcoma.
Yeah.
In our setting, most times the biopsy will probably be an open biopsy because laparoscopy is still developing. Mm-hmm. So I'm wondering, this is a child. There's a lot of expectation from the parents, maybe some constraints, especially financial, and you've taken the child for an open biopsy. What would be the rare cases where you would say, maybe let me go on and do a primary excision before getting histology results, given the situation where we work in? Thank you.
So that is so tough. That is so tough. And I think doing a full like radical cystoprostatectomy, you know, given the morbidity associated with that, and that's a very difficult operation in general, you know, to do that without pathology, I wouldn't do it. I wouldn't do it. I think in that situation, I think you could try to be creative. You can do, depending on where the lesion is, you can do percutaneous biopsies. Now, we generally don't like them because, you know, rhabdo seeds like crazy. But if you can do a percutaneous biopsy and you kind of mark the tract, And you can then excise the whole tract when you do your extirpation. If you're going to go down that road, that's reasonable. You can, I don't know if you guys have like transrectal ultrasounds to do prostate biopsies. You can also do like finger guided rectal biopsies. You may have to be creative doing some percutaneous things, which generally we don't like to do, but I wouldn't be comfortable taking a patient for a big operation without pathology, just given how morbid that is. I mean, there are other things that we can do. I mean, you don't want to take a testicle out if there's no cancer, but you have 2 of them, and the morbidity of that is certainly less than, committing a child to lifelong incontinence, erectile dysfunction, potentially needing appliances. I would be very hard pressed to go to the operating room and just take everything out without some confirmation first.
Thank you.
Dr. Solomon, do you want to ask your question?
Yeah, thank you. Thank you very much. Yeah. Is it audible? Can you hear me?
Yeah.
Yes, we can hear you.
So thank you, Dr. Amanda, for your nice update and your clinical experience. So I'm actually a urologist. So can you mention some of the role of the management option for renal cell carcinoma in pediatric population? Is it the same as the adult one, or can we more promote the nephrons sparing surgery?
So great question. And I'm glad you brought it up. And I'm glad that you're noticing that the 2 populations are different. So generally renal cell is seen much more commonly once patients turn about 12. Okay. So if you have a patient with a renal mass that is 10, 12 years old and older, yes, you should be thinking this could be renal cell. Okay. I think, and as such, the role of biopsy, you could consider it. Okay. Knowing that you might be rolling the dice, and if it is a Wilms tumor, you may have upstaged them, but also know that older patients with Wilms tumor generally don't do as well and do have a more advanced disease. So that may be a gamble you're willing to take. Renal cell, per COG guidelines, renal cell carcinoma is still managed. The surgical management guidelines are the exact same as Wilms tumor. So the recommendation is radical nephrectomy with lymph node sampling. That said, anyone with any urology experience would tell you for small renal masses, we don't need to be doing that. And the safety and the efficacy and all of that's been proven over and over and over again. So I think that is if you have a 15-year-old with a renal mass that's amenable to a partial, that's, I think, where you can easily have a conversation with your oncologist and say, hey, it's probably a renal cell. And we have these data that as long as it's completely resected, and I would say you should do lymph nodes as well, okay, both to appease the oncologist, because then you're kind of following the protocol, but also because we know that in young patients, unlike older patients with renal cell carcinoma, small masses have a very high incidence of having lymph node involvement, and patients with lymph node involvement often have very small renal masses. So I cannot underestimate or understate the importance of lymph node sampling in teenagers with renal cell, which is a little bit different from adults. The role of nephron sparing surgery, I think it hasn't been quote unquote proven in young patients, but I think that almost everyone who does a lot of these kidney surgeries that is a urologist would say, yes, you can absolutely do partial nephrectomies, nephron sparing surgery. It really should be considered with the caveat of doing a lymph node dissection. And the other thing that I would say is very different from older adults. Older adults, it's clear cell renal cell carcinoma, whereas young people, it's generally translocation renal cell carcinoma. And translocation RCC is generally more aggressive. has higher rates of nodal disease. And so yet another reason to make sure that you're doing a node dissection, because we know that renal cell, the long-term survival and true cure is surgical. We can extend things with all of the other TKIs and all of the new PD-1 inhibitors, but true cure remains surgical. So the role of lymph node sampling in young patients, I think, cannot be overstated.
Thank you very much.
I'm just answering a question in the chat. Okay. Please, all of you, feel free to contact me if you have any questions or, you know, whether it's specific, general, you know, how do you get your patients to actually follow up? I struggle with that too. I'm more than happy to help in any way I can.
Thank you so much, Dr. Saltzman. That was an incredible lecture. I will include your email in our post VVP evaluation. And if anybody has any questions, I will pass them along to you. And I think we're good.
Awesome. Thank you guys very much.
Thank you.
Thank you.
Bye, everyone.